Hi, good day, dear colleagues. I'm Dr. Jihad, and our today's lecture is a continuation to the series that we have started about 1 year ago, what surgeons should know, and it's about irritable bowel syndrome. Actually, in this lecture, we are going to talk about irritable bowel syndrome, the definition, diagnostic workup, modalities of treatment, but also we will highlight some causes of chronic abdominal and pelvic pain that may mimic irritable bowel syndrome. Yes, this is a diagnosis of exclusion. We have no single laboratory or radiological investigation that help us in establishing the diagnosis itself. Yes, we use some laboratory and radiological investigation in our journey toward the diagnosis, but to exclude other diseases, not in establishing the disease itself. Okay, if we are talking about the epidemiology, so it's around 20% worldwide with some geographic differences, and it appears in the middle age in the 30s, but usually before 45, and it's more common in female than male. We said that it's a symptom-based disease, and for this reason appears the importance of the definition, and the definition or the criteria for irritable bowel syndrome developed over the past 200 years when we start to report medicine. And as you can see in front of you, I don't want to disturb you, but you can see the criteria and the development of criteria until we reach now what we call it Rome 4 criteria, which appear at 2016. Okay, why this development or this concentration in the definition? Because it is the only what we have to establish the diagnosis. Okay, we will discuss the differences between Rome 4 criteria and the previous criteria, but I think it's better first of all to say what is Rome 4 criteria, or what does irritable bowel syndrome means. And actually Rome 4 criteria, as you see in front of you here, it is a recurrent abdominal pain which occur at least weekly, at least 1 day per week for the last 3 months, with 2 or more of the following. First, relation to the defecation. What does relation to defecation? Improvement or worsening when the patient, she or he, goes to the toilet. Relation to the defecation. Change in the frequency, either increased or decreased frequency of bowel motion, and change in the form of stool, either hard or loose stool. So this is what we call it Rome 4 criteria. The differences, actually the main differences between this definition and the past definition, that as you can see here, relation to the defecation. In the past criteria, it was improvement with defecation. If the patient have abdominal pain and improves when he goes to toilet, so this will be irritable bowel syndrome. But we change the word toward relation to the defecation. It can be improvement or worsening. And other differences between the recent Rome 4 criteria and the past criteria, they use the word abdominal pain alone. Actually, in the past criteria, they use the word discomfort, but they say that discomfort is a general, not clear term, and even not present in all language. So, again, let's summarize what does Rome 4 consists of. It is recurrent abdominal pain weekly, at least once per week, at least 1 day per week for the last 3 months, and one of the following: relation to the defecation, either improvement or worsening, and change in the frequency of stooling, increased or decreased, and change in the form of the stool, loose or hard. And this will lead us to the subtype of inflammatory bowel disease. And as we said, this will lead us to irritable bowel syndrome subtypes. And we have actually 3 subtypes: diarrhea predominant, as you see here, or constipation predominant, or mixed bowel habit. And this will reflect strongly on the treatment of our patient. Some patient with irritable bowel syndrome will suffer from diarrhea, other will suffer from constipation, other will be mixed. To understand diarrhea and constipation, this leads us to review what we call it Bristol classification of types of stool, as you see here, and actually type 1 and 2. This is constipation. Type 6 and 7, this is diarrhea, and here we will have constipation predominant inflammatory irritable bowel syndrome, and 6 and 7 we will have diarrhea predominant irritable bowel syndrome. 3, 4 and 5, these are normal. The bowel motion or the diarrhea and constipation shouldn't be the behavior of the stool all over the time. No, 25% of the stool behavior of constipation consists of constipation or diarrhea, gives its term as constipation or diarrhea. Again, to explain, as you see in this picture, to say that the patient is having a diarrhea predominant irritable bowel syndrome, he should have of his bowel motion only at least 25% presenting as diarrhea, and the other may be normal or mixed. And if he have a irritable bowel syndrome constipation predominant, he should have at least 25 of the behavior of the stool, of the form of the stool, of the consistency of the stool as type 1 or type 2 Bristol. So not the all bowel motion or all day as diarrhea or constipation. This is what we mean by this picture. This is again, they review the Rome 4 criteria. We said recurrent abdominal pain at least weekly, at least 1 day per week for the last 3 months with the onset before 6 months. This is, and two or more of the following: relation to the defecation associated with change in the frequency and in the form of stool based on Bristol classification. Form, consistency, as you want to call it. Okay, let's move to the diagnostic and the clinical workup. Okay, diagnosis and clinical workup depends on history and physical exam as a first step, and this is important to our criteria. The Rome 4 criteria depends on proper history and physical exam, and during taking history and physical exam we should highlight on what we call it the red flags or alarming feature of irritable bowel syndrome, and these features require additional investigations to rule out other disease. Of these features, unintentional weight loss, bloody stool in the absence of benign anal condition, family history of inflammatory bowel disease, colon cancer, celiac disease, night symptom, natural symptom, night fever, presence of the symptoms after 45 or 50 years old, also suspicious and require additional investigations. abnormal abdominal exam, recent usage of antibiotic. These are alarming symptoms. Even with the appliance of Rome 4 criteria by taking proper history and physical exam, and in the absence of red flag, the mean time to diagnose patient with irritable bowel syndrome is 6 years after the onset of symptoms. So you can imagine how the patient will suffer, how long he will suffer until he will reach a proper diagnosis. Okay. Regarding the laboratory investigations, that is, we should be guided by the first step, clinical and physical exam. According to the first step, we will categorize the patient to either constipation predominant, diarrhea predominant, or mixed. If we conclude that the patient is irritable bowel syndrome, constipation predominant, so nothing required more than X-ray in the absence of the alarming symptoms. Nothing more than X-ray of the abdomen to rule out fecal impaction or intestinal obstruction. If we conclude, according to the physical exam and history, that the patient is irritable bowel syndrome, diarrhea predominant, so the workup is a little bit complex. Why? Because some study found that there are certain diseases that can mimic and interfere and misdiagnosed with patients with irritable bowel syndrome. Of these diseases, for example, celiac disease, inflammatory bowel disease, what else? Bile acid diarrhea, microscopic colitis. So we routinely, infectious colitis, we routinely ordered laboratory investigation, even in the absence of the alarming symptom, to exclude these entities. For example, as you see in this picture in front of you, CRP and fecal calprotectin to rule out inflammatory bowel disease. These are routinely ordered. To rule out celiac disease, tissue transglutaminase IgA. Colonoscopy, if performed, it's not mandatory, but if performed, so it's advised to take biopsy to rule out microscopic colitis. We will discuss about each entity in the next few seconds. Bile acid diarrhea, also studies found that about 28% of patients labeled as irritable bowel syndrome, actually they have bile acid diarrhea. So we routinely ordered laboratory tests, but we will see that they are not available in every center, in every country and every medical center. Of these laboratory investigation for bile acid diarrhea is the CCAT. This is a type of nuclear medicine. The patient ingest a capsule and imaging for the bile acid absorption. Also, we have the serum C4, but they are usually not available. Okay, if we suspicious, according to the history and physical exam, an infectious cause, so we ordered the anti-CDTP or anti-vinculin antibodies to rule out post-infectious irritable bowel syndrome. Okay, we said that one of the entity that should be excluded in diarrhea predominant is the celiac disease. As you see in this picture, celiac and gluten intolerance is the same, except that celiac disease is autoimmune disease. They give similar picture, diarrhea and sensitivity to gluten containing food. And we said the workup is testing for tissue transglutaminase IgA, C-reactive protein. Okay, and we said fecal calciprotinin, calciprotectin to rule out inflammatory bowel disease. It's of moderate predictive value. We should rule out giardia if infectious is suspected. And bile acid diarrhea, we talked about bile acid diarrhea and we should rule it out. Bile acid diarrhea actually happens for two reasons. Either the ileum is resected for surgical cause or non-functional, so the absorption of bile is not sufficient, and it gives picture similar to irritable bowel syndrome. And how do we diagnose these patients? Actually, empirically, we give them what we call it bile acid sequestrant medication, such as cholestyramine, and we watch the patient if he improves or not. This is an empiric treatment and diagnosis, because the laboratory tests such as C4 24-hour stool collection and CCAT nuclear medicine test is limited and not available everywhere. The problem with the cholestyramine or with the bile acid sequestrant medication that they are not well tolerated, and we use them in a low dosage at the beginning. Okay, microscopic colitis, it's more common in female after 45 years. So if I have a patient, I conclude that he is or she is inflammatory bowel disease, diarrhea predominant, she is more than 45 years old, so my threshold for colonoscopy should be low. I should push toward colonoscopy, because an entity called microscopic colitis that is diagnosed only in histopathology, the mucosa of the colon is normal, the biopsy under microscope will be affected, and it's similar to irritable bowel syndrome. So that's the investigation journey toward the irritable bowel syndrome. Of course, if we have the mixed type or the mixed subtype, so we use the combination of the laboratory and radiological investigation. Okay, let's ask ourselves, is there a relation between irritable bowel syndrome and surgery? And if the question, is there any relationship between irritable bowel syndrome and surgery? And the answer is yes. The surgery has no role in the treatment of irritable bowel syndrome itself. But as we said previously, the patient needs about 6 years or 6.5 years from the onset of symptom to reach the proper diagnosis. This is the mean time. And during this journey, he may undergo extensive, unnecessary laboratory and radiological investigation looking for the cause of his chronic abdominal pain, and many unnecessary surgery can be done due to this problem. As you see that many patients with irritable bowel syndrome are likely to undergo surgical procedure such as cholecystectomy, hysterectomy, and appendectomy. This actually surgical procedure may be just simply preoperative misdiagnosis, and the patient will not improve. Okay, if we are talking specifically about colorectal surgery, so one of the surgical condition that can mimic irritable bowel syndrome is what we call it symptomatic uncomplicated diverticular disease. Actually, due to the chronic inflammation, we call it visceral hypersensitivity occur in the lower abdomen, and it gives a picture like diarrhea, chronic abdominal pain, but the difference clinically that diverticular disease usually come in older patients. And if we go for for example, sigmoidectomy, treating the symptomatic and complicated diverticular disease, rarely the patient will be satisfied or the abdominal pain will subside. So these are the relation between surgery and irritable bowel syndrome. Okay, let's move to the treatment of irritable bowel syndrome. Okay, treatment of irritable bowel syndrome starts from the basic fundamental issues up to serious medication. It's like a ladder. First of all, we should understand that the most important step in the treatment of this patient is education and reassurance about the benign nature, explaining the benign nature of the disease. As you notice here, that most of the patient comes with mild symptom in the severity. They are mild. So reassurance and education is enough. You can notice here that many patients with irritable bowel syndrome have pre-existing negative experience from the previous provider, and what they want is just someone to listen, to support, and to provide hope in addition to the information. So education is crucial for these patients. You can see in this picture, this is the severity of the disease: mild, moderate, severe. Most of the patients come with mild symptoms, and education, reassurance, and some diet modification is enough. While the other moderate or severe symptoms need pharmacological, psychological, or even pain management treatments. One of the basic, if we are talking about dietary modification, one of the basic conservative measures that are proven in the treatment of irritable bowel syndrome, regardless of the subtype, is what we call it probiotic. Probiotic is this agent which contain beneficial bacteria, and of them which is proven to be beneficial is the Bifido infantis, the probiotic which contain Bifidobacterium infantis. Okay, another agent that can be added as a dietary modification is the peppermint oil. Peppermint oil, actually it's antispasmodic. Yes, some studies says it gives no additional benefit over the antispasmodic medication that we have, but that doesn't mean that we can use peppermint oil to treat irritable bowel syndrome as a first step, and it should be taken on demand, not on a regular basis. You can see that peppermint oil can comes in drops or capsules. Fiber, if we are talking about dietary modification, so fiber can help us in the treatment of irritable bowel syndrome. We poorly understand how can fiber help us, but we know that fiber mainly classified to two groups: insoluble and soluble. Soluble, there are many examples of them, is the psyllium husk, if you heard before. This is an example of the soluble fiber. And soluble fiber actually have greater benefits in irritable bowel syndrome than insoluble fiber. Insoluble fiber such as corn, wheat, bran. Insoluble fiber can be used in a certain narrow field, such as these patients who have constipation with gas or flatus. So we can use the insoluble fiber such as cellulose and methyl cellulose. These are preferred in patients with irritable bowel syndrome with constipation predominant who suffer from bloating and flatus. This is because soluble fiber actually they produce gases and they interfere with the bacteria in the gut. From here appears the importance of the role of the dietitian in the treatment of irritable bowel syndrome. To continue in the dietary treatment, dietary treatment, as a continuation to what we previously said, is important, and you can see that 70% of patient symptoms are worsened by meals. 70% of patients believe that food causes their symptom, and about 90% avoid certain food to prevent or minimize the GI symptoms. Actually, the food allergy itself is not dominant in is not more common in patient with irritable bowel syndrome, but food intolerance is common in patient with IBS, irritable bowel syndrome. And when we say that food intolerance is common in patient with irritable bowel syndrome, food intolerance means celiac disease, means gluten intolerance, means lactase deficiency, lactase enzyme deficiency. These are type of food intolerance. To explain for you what does lactase deficiency, enzyme deficiency means, this is lactase enzyme. It actually destruct the lactose to glucose and galactose, which are monosaccharide, and normal ingestion happen. If it's not present, which is actually present in the brush border of the small intestine, in the surface of the small intestine, so if it's not present, so lactose will be not destructed to monosaccharide, and so diarrhea will happen. We noticed that if we use the diet we offer to these patients, the symptoms in patient with irritable bowel syndrome that have no celiac disease or no lactase enzyme deficiency or no gluten intolerance will improve. The symptom will improve even they do not have this disease. And this leads us to one of the most famous diet regimen, which is called the food map. Food map is a type of diet initially invented in Austria for patients with celiac disease, and it's found that it helps in patients with IBS. Actually, food maps is an abbreviation for fermentable oligosaccharide, disaccharide, monosaccharide, and polyols. What I want to say that it is extremely hard to be adherent to this type of diet, because finally you will find yourself that you need to prevent the patient from everything. So what we have an exit for this problem is we initially at the first week prevent or avoid every thing in the food map diet, in the food map, and the next week we start to add gradually foods, and we start to notice what food can causes the pain, and finally we will avoid just certain amount of food. Another exit or another solution is what we call it the food map gentle type of diet. It is an attenuated approach for the food map. Okay, here appears the importance of the dietitian in our treatment. And finally, after we finished the most basic fundamental principles in the treatment, we know that we have sub types, we have different type, and we will treat the symptoms according to the subtype. Which predominant symptom we have? Bloating, abdominal pain, constipation, and diarrhea. And each category have certain medication and certain diet. If we want to talk in detail about diarrhea predominant treatment, and of the agent that we can use in diarrhea predominant IPS, the first one is loperamide. Loperamide actually is mu-opioid receptor agonist. It decreased the colonic transient time and increase water absorption. It's proven that it helps in urgency and stool consistency, but does it improve pain itself? It's not clear. This we can use it as a first line treatment. If we move to the second step in the management, we have the cholestyramine. We previously talked about the role of bile acid diarrhea, cholestyramine is the one of the agent that's proven for treatment of diarrhea predominant IPS. And the problem in cholestyramine and the newer agent, bitter agent, as you see here, these are newer bitter agent, cholecalciferol and cholecystipol. Actually, these are bitter agent, but we recommend to start with lower dose of cholestyramine and to watch if the patient is improving. We can move to the newer agent. Other proven and as a next step in the treatment of diarrhea, and it's proven to improve the global symptom of abdominal pain, is the rifaximin. As you see here, rifaximin, it is absorbable gut-specific antibiotic that improve the diarrhea, and it has no risk of Clostridium difficile infection, antibiotic associated diarrhea. So rifaximin is a third agent that we can use. Another agent we can use in diarrhea predominant is the iloxadoline or Viprezi. Viprezi is a combined mu and kappa opioid agonist and delta opioid antagonist. Also here it is proven by the FDA and for the treatment of diarrhea predominant IPS. The problem in this medication that it may cause pancreatitis and sphincter of OD dysfunction, which primarily occur in patients without gallbladder. Other medication that is proven for the treatment of diarrhea predominant IPS is the 5-HT3 antagonist olicitron, but with low dose because we fear of the ischemic colitis. We start with low dose. Okay, one of these medication of this group, among this group, is the ondansetron. We use this agent for treatment of vomiting associated or vomiting in patient with chemotherapy. Okay, in constipation, an agent that treats constipation, first of all, what does constipation mean? Constipation can be hard or lumpy stool according to Bristol classification. Straining during defecation. You need more additional power to defecate. Sense of incomplete evacuation. This is also described by the patient as constipation. Fewer than 3 bowel movements per week. This is also described as constipation. And sense of anal blockage, anorectal blockage, sensation that there is blockage, also defined as constipation. And the need for manual maneuver to evacuate or to facilitate defecation is also defined as constipation. Constipation, we already said that irritable bowel syndrome is one of the disease of the syndrome that comes as constipation predominant. But we have other entities such as functional constipation, opioid-induced constipation. Functional constipation, okay. What I want to say, it's not, the treatment doesn't actually change or altered by the change of these diagnoses. And actually differentiating between irritable bowel syndrome with constipation dominant and functional constipation is a matter of academic research. Actually, the treatment is the same. Here you can see some risk factors that are associated with constipation, such as medication, opioid, anticholinergic, tricyclic antidepressant, calcium channel blocker, etc. Mechanical causes such as colon cancer, metabolic such as DM, hypothyroidism, myopathies, amyloidosis, scleroderma, neuropathy, Parkinson, spinal cord injury, psychiatric depression, etc., pelvic floor, anal fissure, pelvic floor problem, anal stenosis. These are risk factors for constipation. The treatment of constipation, most of the patients will be treated with the first line therapy, which is fiber, which include only fiber supplementation, with the addition of the most common treatment, the polyethylene glycol. Most of the patient will improve with this. Okay, where you can see here that most of patients improve with fiber and or polyethylene glycol. Okay. If there is no improvement to fibers and polyethylene glycol, we have what we call it secretagogues. These are agents that drive the chloride to the lumen of the GI, and so the water will follow the chloride and we will have ultimately diarrhea. These are 3 agents, no differences in their effect. These are lubiprostone and linaclotide, and plecanatide, Trulance. Okay, these are 3 agents under the group secretagogues. Okay, we move now to another way of treating the IBS with some psychological treatment, or what we call it the neuromodulation. Okay, treating patient with neuromodulation, patient with irritable bowel syndrome with neuromodulation is indicated in cases of moderate or severe symptoms, because we believe that irritable bowel syndrome alone cannot cause that severe pain. The primary bowel dysfunction only responsible for mild symptoms, whereas moderate and severe symptoms require primary CNS pain dysregulation, and from here appear the neuromodulation medication. Actually, we have an entity called the centrally mediated abdominal pain syndrome. Actually, these are aggravated, the initiating factor is in the abdomen. But we have what we call it a visceral hypersensitivity. Any mild local infection can be precipitated or can be imagined in the brain as severe pain, and this is the cause. The cause is psychological more than organic. Okay, and you can see here that we have an entity called centrally mediated abdominal pain. These are due to visceral hypersensitivity, and again, irritable bowel syndrome alone without the combination of CNS dysregulation will not cause more than mild symptoms. Okay, you can see here that the psychological treatment or the neuromodulation is like a ladder, starts from basic behavioral, cognitive behavioral treatment, yoga, relaxating strategy, and we can add, if it is severe, we can add tricyclic antidepressant or selective serotonin reuptake inhibitor, or selective serotonin and norepinephrine reuptake inhibitor. So we start depends on the severity of the disease. You can see here we start with CBT, cognitive behavioral therapy, treating the patient, teaching him about his symptoms, hypnotherapy, and if it's severe, we use the medication. Okay, we have, as we said, we have three main drugs. The tricyclic antidepressant, which is preferred, which is we primarily use it, and it is preferred more in diarrhea predominant because it has an anticholinergic effect. Yes, we have selective serotonin reuptake inhibitor and serotonin norepinephrine reuptake inhibitor, but we usually use them as not a monotherapy, but as an adjunct or combined therapy with tricyclic antidepressant. As I said previously, tricyclic antidepressant is preferred in diarrhea predominant patients. They have anticholinergic side effect which can help us in the diarrhea. The strategy of dosing is start slow and go slow. These are the tricyclic antidepressant, amitriptyline. We see it frequently when we take history from patients. These in the green are the preferred two agent, nortriptyline and dizipramine. Okay, as we said, selective serotonin reuptake inhibitor is not used as a monotherapy but combined with other treatment. These are selective serotonin reuptake inhibitor. Another agent under the neuromodulation type of medication is the pregabalin and gabapentin. The pregabalin is recommended better, especially in constipation and mixed type. These are the lyrical, pregabalin. We said neuromodulation is not only medication but also behavioral treatment, and it can be, as you see here, yoga, etc., exercise, singing, slow deep breath. Okay. This is a novel approach for the future in the treatment of irritable bowel syndrome. It's type, I think, you can see here we have the fecal transplant. It's not proven till now. Fecal transplant only proven in diarrhea associated diarrhea due to antibiotic, I think. It's not proven, but we can just mention it as a future approach. Mast cell stabilizer and other anti-inflammatory drugs. And you can see here we talked about the 5-HT3 antagonist, and you can see here modulating the central pain mechanism IPS-TIM device. It is just for remodulation of the signals that comes from the bowel, which is aggravated, which is increased, comes from bowel, and we using this device actually attenuate the response to the pain. Okay, we actually reviewed the treatment of irritable bowel syndrome. We said that it starts with education, then we moves when a step up a little bit when we talk about peppermint oil, and when we talk about the probiotic, then we move to the when we discuss the rule of fiber, soluble and insolubles, and we highlight the importance of dietary treatment and the low food map diet, and then our treatment was directed by diarrhea predominant or constipation predominant. We said diarrhea, we start with loperamide, cholestyramine, rifaximin, then we go to ulixadoline, and we go to the olicitron, which may cause ischemic colitis. Constipation predominant, we said it's two line, either fibers and polyethyl glycol, or we move to the secretagogues, which bring the chloride into the lumen, and so it bring the water in the lumen. And these are three medications similar in efficacy. And we move to the neuromodulation if there is severe pain, and we said that it can be simple maneuvers such as cognitive behavioral treatment, yoga, relaxation, breathing strategy, or medication. And we said we have two medication, tricyclic antidepressant, the preferred, selective serotonin reuptake inhibitor. We talked about pregabalin and the newer technique. We now move to the chronic pelvic pain. Okay. Irritable bowel syndrome and pelvic pain. We said that irritable bowel syndrome mainly causes abdominal pain, but it found that it may cause pelvic pain, especially in female. You can see here, IBS symptoms are reported in up to 40% of patients with chronic pelvic pain, especially in women that have lower back pain, aged than more than 40, depression, etc. Okay. One of the entity that we should consider when we talk about IBS irritable bowel syndrome, female, pelvic pain is what we call it the pelvic floor dyssynergia. Actually, it's weakness in the muscle, and one of the investigation that should be ordered is the anal manometry if dyssynergia is suspected. The treatment of IPS and pelvic pain is with neuromodulator, and you see here the classic information: tricyclic antidepressant for diarrhea predominant and selective serotonin reuptake inhibitor, and neuroepinephrine reuptake inhibitor is for constipation or mixed behavior. Okay, mixed predominant. One of the treatment for patient who suffer from pelvic dyssynergia or IPS, inflammatory bowel syndrome, with constipation predominant is what we call it the biofeedback therapy. Biofeedback therapy, to explain for you, it's actually, as you see in the picture in front of you, it is connecting the patient to a monitor. This monitor will show you the signal of the involuntary muscle contraction and relaxation in, if we are talking about the pelvis, in the pelvis. And so you can consciously control the contraction and relaxation of the muscle in the pelvic floor. In another word, it's teaching the patient to consciously defecate. It's a nice modality of a treatment. I was told by one of my seniors about this treatment, and I think it was just a type of imagination, or but it exists. Actually, I'm not sure that it exists in my center, but we have biofeedback therapy. It is helping the patient to control the involuntary muscles by different way. Okay, functional anorectal pain. We are going rapidly to review the causes of this pain because it mimic irritable bowel syndrome, and we should at least understand that there is a concept called functional anorectal pain. Okay, functional anorectal pain that can mimic irritable bowel syndrome, according to Rome, 4 criteria. These are levator and Nye syndrome, unspecific functional anorectal pain, and proctalgia focus. Actually, the differences between them, actually, it's the duration of the pain. These actually present as a pelvic pain. If we want to talk about levator and Nye syndrome, so as you see, it's a chronic recurrent rectal pain that lasts about 30 minutes with tenderness at the puborectalis muscle, and of course with the exclusion of other systematic disease. This is a nice picture. Sure, we can imagine the levator and Nye syndrome. You can see here, this is the puborectalis muscle, which is one of 3 muscles of the levator and Nye muscles, and some theory says that it's due to the inflammation of the puborectalis muscle where it inserted in the pubis. So with digital exam, we have tenderness around the puborectalis, and it can be increased or precipitated by or associated with pelvic injury, childbirth, history of pelvic or spine surgery, psychological disorder, anxiety, and depression. Modality of treatment: digital rectal massage, one of the proven modality of treatment. Also, we have the neuromodulation. We have botulinum injection, but of less efficacy if we compare it to digital massage. And also we have the local anesthetic injection combined with steroid. Okay, okay. Proctalgia fugus, it is an, the kids are playing. Okay, proctalgia fugus, it is an extreme pain at the rectal region, but the difference is the duration. It's from seconds to, as you see here, it lasts from seconds up to 30 minutes in the absence of tenderness or organic problem. It can be associated with anxiety, it can be associated with psychological stress, but also it can be familial, and it is familial, so we note that the familial type is associated with hypertrophy of the internal anal sphincter. Another etiology of the proctalgia fugus, it's like, to describe for you how the presentation will be, it's like severe intense anorectal pain with no causes that appears for seconds and disappears. And so even the patient is not seeking a treatment because it's just a matter of seconds. Other causes of proctalgia fugus is the pudendal nerve neuralgia. As you see here, this is the pudendal nerve. Any lesion, any compression to the pudendal nerve can cause proctalgia fugus. One of the treatment is, of course, medication, education, explaining the patient, teaching the patient about the symptoms. Here you can see changing the position, reassurance, warm bath. Nifedipine can help, topical nitroglycerin can help, passing flatus, if it is socially acceptable, is a treatment, and enemas can help. One of the treatment I want to mention is the use of albuterol, and of course the biofeedback is a treatment for these symptoms. The biofeedback can be a modality of treatment not only for pelvic dyssynergia and IBS constipation predominant, but also for levator and Nye syndrome and proctalgia fugus, which can be, as we said, familial or neural pudendal nerve neuralgia and other causes. These are the treatment. Coccygodynia also can cause pelvic pain, and coccygodynia, this is the coccyx. It may cause pain, is defined as pain or discomfort around the coccyx, including the sacrum, anorectum, perineum, which is aggravated by prolonged sitting and hard surface. These criteria and the previously mentioned criteria should be longer than 2 months. You can imagine from this picture that leaning backward will aggravate the pain, and the diagnosis is actually a clinical. You will elect a tenderness, either external exam or transrectal exam. You will elect tenderness around the coccyx. It can be due to trauma or idiopathic, due to pelvic floor spasm, inflammation, hyper or hypomobility, etc. So we have two types: trauma or non-trauma or idiopathic. Okay, treatment can be simple manipulation, massage therapy, which is effective, and other treatment modality. Also, the biofeedback is a known modality of the treatment. This is also how to treat these patients. The MRI is not required, but we may exclude other serious disease such as degenerative spine disease, tumor, metastatic tumor. What we use, this is a donut shape cushion to sit on, so there will be no pressure on the coccyx. Also, non-steroidal anti-inflammatory drug we can use. What else? These are okay. These will improve the symptoms in 90 percent of the patient. Other modality of the treatment in coccygeodynia is what we call it the impar ganglion impar blockage. Actually, this is the impar ganglion, and we either transrectally by surgeon or CT guided, we block this ganglion as you see here, and this is an effective treatment using steroid or local antiseptic. The final step in the treatment of coccygeodynia is the coccygectomy, removal of the coccyx. We talked about pudendal neuralgia when we talk about proctalgia fugax. We said it's one of the causes. So pudendal neuralgia can cause pain in the pelvis, and pudendal neuralgia, it's actually diagnosed based on the territory of the pudendal nerve, of the area where the pudendal nerve give its branches. As we know, the pudendal nerve is from S2 to S4. It comes through the Alcock canal. This is the Alcock canal between the sacrotuberous and the sacrospinous ligament over here, sacrotuberous and sacrospinous ligament, and then it gives branches, rectal, perineal branches, and to the genitalia. Also, pain at these sites can actually increase the suspicion of pudendal neuralgia. We have problem in diagnosing similar such disease, pudendal neuralgia, because what we only depends on the pain that is described by the patient in the territory of the pudendal nerve. Okay, yes, we have MRI neurography, but it is not extremely specific. We have also criteria that can help us that, but it's not actually 100% specific and sensitive. The most specific and sensitive is the empiric treatment, either surgical or non-surgical, which will relieve the pain. This is the most used type to diagnose pudendal neuralgia. As you see here, making the diagnosis of pudendal neuralgia is difficult and patient may suffer. Here we have criteria. You can see here 5 criteria. Pain in the anatomical territory of the pudendal nerve. Pain is worsened when by sitting due to the excessive pressure. Pain is not working the patient at night. Pain is not objective sensor loss. Pain does not cause objective sensory loss on clinical exam. Pain is relieved by anesthetic pudendal nerve block. Pudendal nerve block can be performed by surgeon transanally, transvaginally, or by CT guided. This is a patient lying on his abdomen, and this is the radiologist. We can use neuromodulation and neuroablation. Neuroablation is CT guided cryoablation to destroy the nerve and to decrease the sensation. The operative approach, we can approach the pudendal nerve either transperineal or transgluteal. We have Istanbul approach, which is the laparoscopic approach over here. We have also laparoscopic approach. This is Istanbul technique, which is pudendal nerve. Okay, surgically what we do is we release the compression in the pudendal nerve, which is most commonly in the Alcock canal or the infrapiriformis canal. We release this compression. So we actually finished our lecture. We reviewed the the irritable bowel syndrome and other causes of chronic pelvic pain. Thank you. Bye bye.